All right, CTAF panel members, can you please take your seats? We are going to start the roundtable. And I'm glad I had the chance to introduce the roundtable. Stakeholders at the roundtable around the implications for the healthcare system. How do we actually make use of the evidence to make wise decisions? What are the policy options? And how do we identify ways forward where hopefully people can work together? So I'm going to just start by, again, moving away. Hopefully this will pick up. Am I on? Yeah, okay. By the way, I had a representative from a pharmacy and therapeutics committee come up to me during the break and just said, thank you. You do not know how hard this is for all of us, and the work that this group is doing is going to be very, very helpful. Not just the tables and all that, but the discussion that you all had and the votes. But I kind of want to cast it into stark relief by saying, in a way, it feels like we have a real crisis. We have a cure that we can't afford. If you believe the numbers that were presented as part of the budget impact, both on a cumulative basis and on the per member per month basis, there are numbers that I haven't heard any payer say that they can manage. So in much in the way that we stipulated evidence issues for the panel, I almost feel like I want to turn to the policy roundtable and start by saying, should we stipulate that we can't afford to treat all the patients who would be eligible for the treatments we might like to use? Is that a fair stipulation? Ryan?
Well, I mean, I couldn't ethically run a national advocacy organization representing 250 organizations around the country and say that I think that this country can't afford to provide a cure for people who need it, who are living with the crisis is the fact that we have millions of people with hepatitis C, the overwhelming majority who don't know it. We need to identify them. We need to bring them into care and then let the doctor and the patient work out what treatment is needed. And the payers, it's up to the payers to work out, but as a patient advocate, there's been so much focus on the price of the drugs and how it's going to bankrupt the system. I think we don't really know how many people are going to be identified in the next few years. We have more drugs coming down the pipeline. So I feel like we're getting hung up really quickly on the fact that we can't cure people and not as much on the fact that we actually have this revolutionary era of treatment that really provides an incentive to bring people into care.
Well, actually, I posed the stipulation more as a hypothetical. Could we afford at this price to treat all of the patients who have hepatitis C who might potentially present with the most expensive new regimens? I mean, we have the treatment guidelines from the specialty societies, the AASLD and the IDSA, are calling for the use of cimeprevir plus sivosbuvir for, in a sense, the first treatment option for a certain, sizable number of patients. Rena, is that feasible for healthcare systems, do you think?
Well, I'm not part of an insurance company. I would guess that that is not at all feasible to treat the entire hepatitis C population up front, all comers, right now. I can't imagine how that would be feasible without bankrupting our system. So if what I really wish for is that we could push back on the price rather than have to make patients wait or be denied. But since we don't have an ability to change the price, then we have to decide which patients are the most urgent or that we think are the most urgent to be treated now before we wait for a bigger menu of options which may lower the price and provide more data.
We get a real world perspective from a payer, Sylvia. So let me just, so From a real-world perspective, and I'm not sure if you know everything that Anthem or WellPoint has been doing in this area, but how are they viewing the affordability of this and their options relative to other treatments? Can you?
Sorry. I'm going to make the generic statement that payers aren't just publicly traded companies that care for commercial members, that payers are actually taxpayers in Medi-Cal. And Medi-Cal has made some decisions that I, as a former Medi-Cal provider, don't agree with. As far as a follow-up visit's $15. I think that's kind of a different kind of policy decision. And so I think, particularly when we know there are many good things like colonoscopy to screen for colon cancer that are inappropriately overutilized, that squander resources, we have a cure or we have an effective treatment that is very expensive, and the purpose of using experts is to really make some very hard discussions that are evidence-based about how do we best use resources, and that hopefully these evidence-based decisions will not only be in the vacuum of insured commercial members, but also 25% of the people with insurance in the state are Medi-Cal beneficiaries. And we've made decisions about Medi-Cal reimbursement that have affected access, and this is going to be another potential access issue for a large percentage of the individuals who are living with the disease. So I think it's a time for some rigor around evidence. It's talking about priorities. And there may be better treatment down the road, but I think it's not just commercial people with good insurance that we need to create some discussion around.
So it seems to me that among the different options, I mean, it's fair, obviously price will come up, and I'm sure we'll talk a little bit more about it, but it's one of the many moving parts here. I mean, I could imagine the policy reactions as being the following. One is some people may decide that the evidence isn't adequate to support the use of these new drugs at all, and we should just wait until there's better evidence. This group today, Dan, how would you summarize the votes about the evidence related to these new drugs? If you had to summarize, and you're very good at this, what would you say the panel has voted regarding the evidence supporting these new drugs?
I think the panel, I think the new panel was very generous in interpreting the data. I think we are ordinarily much more rigorous. And I think the panel was willing to give, on the first vote, not the value vote, had a tendency to give the benefit of the doubt to the scant evidence that was available. That would be my summary.
So, because my quick memory is that most of the votes were in favor of the adequacy of the evidence
Yes.
for multiple different patient subpopulations. So again, I could imagine the policy response. By policy, I mean kind of everybody, because we're all, in some ways, in this together, in many ways. One response would be to make, and some people may make other judgments about the evidence that it's not adequate to treat anybody at all. One is the kind of more general or linked question of whether we should wait on a large percentage of patients until there are other options and kind of see, and more evidence and all these other things. A third approach would be to use medical policies through restrictive patient criteria, clinician criteria, fail first policies, and we'll talk some more about those, and other ways to try to limit the number of patients who would be treated. And the fourth would be to mobilize some kind of policy action to try to bring the price down. So all of those are kind of potentially on the table in a way. And so, Amandeep, let me turn to you. And that may not be the full menu that you're thinking of as hepatitis champion for Kaiser Southern California, but what are you thinking of doing in terms of managing this tension between the votes on the effectiveness and the votes on the value that we've seen today?
I mean, this is a struggle which we all have, even as a clinician before this forum. Who are the right patients who need to be treated now, and who can wait for all oral medications to come out? So I think as how I'm looking at that we have effective treatment, but we need to also know who are the patients who will get maximum effectiveness from this treatment. So to know which patients will benefit the most and follow these patients and learn the long-term outcomes of these patients. So there's a lot of initiatives which are going to be done at the Kaiser Permanente point of view in regards to following up these patients, making it sure the right patients get right treatment, and have more information, as we all understood that the evidence is, the medications are effective, but the evidence is scant.
So what does that mean in your own thinking for patients who aren't as sick as they usually are when they get to your office, but they may have just found out that they're hepatitis C positive, they are asymptomatic, they do not have a very far advanced liver fibrosis? Do you have any sense of how your system is going to interpret the evidence on how best to treat or not treat those patients?
So like I said earlier, that it's more of a shared decision-making with the patient and yourself. At this particular time, the preferences we have in regards to medication combination do involve interferon and ribavirin, which we know, all of us who treat patients with that medication combination, that patients do have significant side effects from that. So that's where I will have a shared discussion with the patient in regards to patients normally are at this time, what I have encountered, yes, they have this information that there are new medications coming out, and they want to get an assessment from the physician what stage they are in and what they have coming on in regards to their treatment. So I think it's, again, a shared decision-making, which will be very important. And I think probably rushing a patient into treatment with getting significant toxicity from the medication will be not the right approach to take. So the patients who are stable, asymptomatic, and we have assessed and stratified that those patients have earlier disease, and they probably prefer not to be not able to work or not able to go back to school or concentrate on their studies, could wait for new medication or oral medications to come out and do better. And probably you did them a favor by giving them that information early on and not rushing into treatment.
But Rena, there is an all-oral option. There's sofosbuvir plus cimeprevir. Tell us what you think of having witnessed the vote on the evidence and the way that I know you're helping people think about it within the VA system. How are they going to interpret the evidence and apply it to their treatment choices? I know that there are phases of the moon and going on with clinical guideline developments there. So tell us what you can.
I'm not going to speak just from the perspective of the VA, but from my sort of summary of where things stand and how people look at this. I think that people who understand the evidence know that the combination, the cimeprevir-sofosbuvir combination, has very, very limited evidence right now. However, for those patients who are genotype 1 and interferon ineligible, especially if they have advanced disease, there are no options that include interferon. So the choice for a genotype 1 interferon ineligible patient right now, today, is either cimeprevir, sofosbuvir plus minus ribavirin, or sofosbuvir plus ribavirin. And in both of those regimens today, I would say everyone would say that the data is insufficient, but you might still be faced with making a decision with that patient. So I think in the VA, and I think among knowledgeable providers, they might offer that patient the cimeprevir-sofosbuvir combination. If it's not a cirrhotic patient, I think most providers who are knowledgeable might say, why don't you wait? Wait either till there's more evidence on these two regimens, or why don't you wait until there are other regimens for that interferon ineligible genotype 1 patient in maybe even 1 year. As for interferon-eligible patients, interferon eligibles who are genotype 1 and cirrhotic, that patient you might offer just the sofosbuvir pegylated ribavirin combination. But I think that many providers, I don't want to speak for everyone here, but it's pretty hard to offer someone a regimen that includes interferon today unless they are cirrhotic. If they're cirrhotic and they're eligible, that makes sense. If they're cirrhotic and they're ineligible, genotype 1, then we really only have two choices today. Does that answer your question?
No,
Okay.
I think it did. Well, let me now reflect back with the panel again. I asked Dan for his summary. Any other reflections, especially for those of you who've been around through CTAF panels? I know that CTAF hasn't looked at drugs that often, may have never looked at a breakthrough drug. But what's your own reflection on the evidence and how it's been voted on, and in this kind of dialogue with people who are going to use it in systems of care? What additional things would you like to say? Rita?
So we just heard from the clinical experts that there is not sufficient evidence now to really be conclusive, but we like to treat people. The problem I see is that there's no incentive at the point you start treating to gather clinical evidence. You know, we're talking about generally very expensive and industry-sponsored trials, and any kind of data that might possibly narrow, doesn't happen. And so I don't see that we're going to get better evidence if we start using a drug particularly widely. And, as I say, worry when I see direct-to-consumer advertising campaigns about how it's going to be used. We don't get better evidence, and this is clearly a big problem. I mean, because not only are the studies short-term and open-label, but it's a very expensive drug, and it's going to have tremendous impact for every health system. And, there are opportunity costs, other things that won't happen and won't get paid. I think we need to talk about that.
So extrapolating clinically from what you're saying and now reflecting back with Ryan, and a little bit with what Rena and Amandeep were saying, how does the patient community feel about the idea of you're tested, you find out you have hepatitis C. Good news is your liver looks fine so far, just maybe minimally affected, and the treatments aren't great so far, so you should wait, and we'll watch to make sure your liver doesn't get worse. Is that the conversation what do the patients think should be done with the kind of conversation with patients? Yes.
Well, I'll start first. So I worked in the HIV world for many years until moving into viral hepatitis. There is not a organized hepatitis C community the way there is in HIV. So the thought that there's really a group conversation going on and that we're really getting that information isn't really happening. I think the community is not talking about the fact that treatments aren't very good right now. If I heard you correctly, the word is out that we're in a completely new era of treatment, and that there's more coming on board, but that we're looking at the cure for the overwhelming majority of people, and we're looking at an all-oral regimen pretty soon. Making a treatment decision is individual-based. I'm going to talk, the guidelines, I think, should drive discussions, the guidelines from ASLD and IDSA, I think should drive payer decisions, I think should drive discussions between physician and patient. Some patients who come in asymptomatic and very little liver disease may decide that they want to wait, but cost will not be the driver for that patient. Cost may be the driver for the payer, but I would never think, if I were HIV or Hep C positive and I came in and somebody said, there's this great treatment, but you're pretty healthy, can you hold on down the line because you'll bankrupt the system? Like, that's not how a patient's gonna think. So there's a lot of decisions. Some people may wait because they're just not ready to take treatment. Some people may wait because they want to see what's down the line. Some people may wait for a variety of reasons. I think it's a very personal decision between the provider and the patient, led by guidelines and with reasonable reimbursement, and not an immediate jump to, the cost, we multiply the number of people who probably have hepatitis C by the cost of this drug, and we suddenly bankrupted the system. This is something that's going to go on for a long time. We're not even close to ramping up testing programs. And I think it's just to slow down just a little bit around the conversation around bankrupting the system and to think more about how it's really happening in the real world.
Well, I will note I've looked in the business community literature, and they do anticipate much higher costs coming downstream. And I saw two estimates from, well, Bloomberg said that we'll be spending $100 billion on these drugs in the next 10 years in this country alone. So there's kind of we'll delay, treatment for some clinical reasons, but the idea that the cost will necessarily be lower and that the cumulative cost will still be somehow manageable, I'm not sure that many people, at least in the payer community, are looking at that, or even in the manufacturing community. I don't think they're looking at smaller numbers over the 10 years. Sorry? Oh, sure.
Sorry, I forgot a piece. There's also, it came up a couple times this morning, there is the concept, and I know this group didn't grapple with that, but there is the treatment as prevention aspect. There may be folks who will want to treat because of concern about transmitting the virus to others, and I think that factors in. So even if somebody's asymptomatic and in perfect health, there are reasons out there for some folks to need to go and want to go into treatment and be cured.
Okay. So you mentioned the guidelines, and I know that I've got them printed out here just so folks have a chance to know that there are specialty societies that have put out guidelines online, and they're going to be updating them as time goes on. And I'm sure that they will be looked at by a lot of folks. The process for creating them was supported by manufacturers, and the conflict of interest information is available online for both sets of these. But they're also, insurers will use prior authorization criteria to manage, these kinds of situations. So I thought it would be helpful for this group to walk through these colored documents that were in your binder, because it gets to some of these questions about decisions around specific kinds of patients who might or might not start treatment or at least get coverage for it. Does everybody have these? It was our best attempt, and in the crowd you've got these too, I think. Not perfect, but what this is not, and I want to be really clear, this is not a draft set of prior authorization criteria. This was an attempt to cut and paste existing prior authorization criteria that are publicly available from different insurers and pharmacy benefits companies in a way that will allow you to compare differences around the language that's currently out there. Where you see type that isn't highlighted with any color, it means pretty much that it was similar across all or most of the different payers. So I highlighted the ones that were distinct because I thought it would help focus a conversation. So you've got one for Cimeprevir and one for Sivosbuvir. I will highlight also that among these colors, the green is from clinical expert input, so it's the one that's kind of which one of these doesn't belong. The others are all from payers, but the green is from clinical expert ideas. So let's look at the Cimeprevir one first. Health plans, et cetera, have had a little bit more time to think about this one. So I want to ask about the fact that number 2 under patient criteria says the patient must have a diagnosis of chronic hep C. You always have to start with the blindingly obvious in these prior auth criteria, with compensated liver disease. So one of the questions I thought would be useful is to get your input on how should payers, what are the options and what do you think is best practice for defining what compensated liver disease means? Some of the health plans say nothing more than that in the prior authorization criteria. So I'm not really sure how they interpret that. But others have extensive, and on the second page here, you'll see a long description of compensated liver disease in blue from Anthem Express Scripts. So I guess one of the questions I'll reflect back first, maybe Todd, when you think of prior authorization criteria and you look at some of this language, does it make sense to tie it to the Child-Pugh-Turcotte classification? Should it be framed some other way? What's your what would your guidance be for folks?
I think it's very straightforward if we're talking about an interferon-containing regimen. So the child PU classifications, what's highlighted in blue, have been clinically valuable to hepatologists for decades. And it's the dividing line between a compensated cirrhotic, which is a child's A cirrhotic, and decompensated is B or C. And you would be ill-advised to use interferon in a decompensated patient outside of a transplant center. So this is cut and dried. I think the question would come up, what are we going to do with these patients when we have two direct-acting antivirals, such as the Cosmos study, which these patients were not included. But what do we do with them when we have something like that?
So just to be clear, you read this from, I don't know if it's the top down or the bottom up. You were thinking of how sick patients are when it's not a good idea because the only data is on those who are less sick. Think about it from the other direction. What about the patient who would not be considered to have liver disease?
Well, I would argue that anybody who has chronic hepatitis C has some degree of liver disease, and you can split hairs as to how you're going to define that. But if you were to do a biopsy in someone who's viremic, you're generally going to see some amount. It may be minimal inflammation, but it's defined as a chronic liver disease once you have 6 months of viremia. And then we have to talk about grading in terms of inflammation and staging in terms of fibrosis. But that point I think is coming across as avoid treating the decompensated
Right.
patients.
But in principle, a patient who had a child Pew-Turcot under 5 would not have well-compensated liver disease. They would not have...
Well, this classification only comes into meaning when you have cirrhosis. This is cirrhosis, and then patients ask me, how bad is my cirrhosis? Which stage am I in? This is how we define classes of cirrhosis. So if you don't have cirrhosis, the CTP score becomes somewhat meaningless, and it's impossible to be less than 5.
All right. John, as a insurer, and you think about prior authorization criteria, could you imagine using something like this to make sure that appropriate patients on the severe end, but also maybe on the asymptomatic end, are addressed? I'm not. When I read this, I have to be honest, I was interpreting this both ways, as making sure that patients who weren't too sick would be treated, but also making sure that they had some level of liver disease, as opposed to literally just showing up on a screen positive and maybe the liver biopsy shows nothing and they have no blood findings. So you correct me, but that was the way I was looking at this.
I'm looking at this in terms of, I think that the meaning is really to exclude the decompensated. There's a different discussion to have about if we're forced to ration care, which we are. I mean, we've been doing that. I've been doing that for a long time in terms of just the interferon in general and the new protease inhibitors from 2011. We had a very big bottleneck coming into our clinic. It was about a 6-month wait to get in, to be seen, to be potentially treated. So rationing isn't new to us. Nobody wants to talk about it or hear about it. But if we're forced to ration, then we can have a different discussion about how would we go about doing that. But I think this question really points out, and pointing out the highlighted in blue is clearly trying to protect those patients who you may harm if you use interferon.
Understood. So maybe I won't hit you with this question unless you have something you want to say about it. Okay, because that helped address. Does anybody else, this was just one of the pieces I wanted to tease out because I found the language of the different prior auth criteria to be quite different and how specific they were in the way they framed this. So Rena, looks like yeah.
I just want to agree with Todd. I mean, I think this is a terminology issue here about compensated liver disease, that the reason that this is here is to exclude the decompensated, and the term compensated and decompensated should only be used when describing cirrhosis. So if your question was, what if the patient has hep C but has no liver disease, that would need a different terminology.
Interesting. All right. Well, let's just be frank about it then. Should patients who are hep C infected and I assume they'll get a liver biopsy, and there's really minimal findings, if anything. They're otherwise completely healthy. Would you provide any kind of general guidance to payers or others that these people really are at the low end of the group that should receive coverage for these drugs, or should it always be full coverage, shared decision making? I mean you mentioned rationing. If we have to prioritize, let's use that word instead, should we not treat the healthiest patients?
Well, I think if you're going to look at it that way, and I understand we do have to in terms of what we have available to us. I want to treat, and what I'm focusing on treating right now are patients with cirrhosis, advanced fibrosis, liver cancer awaiting transplant, post-transplant off-label with significant recurrence, patients with extrahepatic manifestations I think need to be included in that, with cryoglobulinemia and potentially renal disease or lymphomas, which are a smaller proportion. And I think the patient with earlier stage disease, the conversation I'm having is that better things are coming, and to talk with someone about, oh, better things are coming maybe 3 to 5 years, that was challenging. That's what we were doing in the late 2000s. There were a lot of unknowns and hopes. And now we have, I think, much more concrete evidence and deadlines. If you look at the phase 3 programs for Gilead and AbbVie, both of which have been released in a press release, those are incredibly compelling. And the timelines for one has already been submitted and the other should be submitted very soon. So to be able to talk to a patient and say, better things are coming, and this is the timeline, and it's a very realistic timeline and short timeline, that makes it easier. But that's still not going to solve that's kicking the can down the street a bit in terms of the rationing. Because what are we going to do at the end of this calendar year? We're going to have another one of these meetings, and the drugs aren't going to be any cheaper.
And indeed we will. We will have fewer votes on value, I swear. But we will have, this topic is a one bite at the apple that we'll have to continue taking. Meg.
So I'm a primary care physician, and I am in a system where we have the reminders enacted to order the Hep C screening test in all patients who meet the U.S. Preventive Service Task Force recommendation, age born between 1945 and 65. So I'm ordering those tests. So the question about whether we're ramping up to do this, we actually, in large systems like Sutter and like Kaiser, where we use Epicare or other places where reminders are there and we do what we are reminded to do, the numbers are going to be huge. And a related question then is, as a primary care physician, and I think like many, I pride myself on saying I do all I should do before I send a patient to a specialist. I don't just say, okay, Hep C positive, you go. Or like I do, hypertensives don't all see cardiologists. So to your point about kind of what you're going to do with the patient, if a patient doesn't have evidence of cirrhosis, what I'm hearing is that we should be screening the patients and then maybe some other tests to try to define their degree of cirrhosis and not biopsying all of them. You mentioned something about, well, they'll get a biopsy. I don't think they're all going to get biopsies. You do LFTs, you do the FibroSpect or something else. And then policies would be enacted to say, these are the ones you should be sending to have the discussion, just like we do for all other conditions where you have to triage those who actually need the specialty conversation to determine the interventions. So I'm kind of asking it again, but if we think that there's this enormous number of patients who are going to be Hep C positive, what should we be doing? It's the pre-story to the decision about which drug you're going to use. It's which one should, how you should screen them, and then which ones do you want at your doorsteps? And maybe this isn't the right time to ask it, but it's part of the triaging issue that precedes the cost questions.
So in Southern California, Kaiser, we have thought about this and we have already implemented where when a patient is antibody positive, we do send a reminder to the PCP to send a viral load that automatically generates a genotype. The lab system is all set up. And then we have a reminder where we want patients' hepatitis B status, HIV status, ultrasound, liver test, albumin, everything to be checked. And we encourage our primary care providers to send all patients with hepatitis C after all that is checked to see a gastroenterologist or an infectious disease doctor. So we are, and then we have a safety net program which has been in place where anybody who's hepatitis C antibody positive but has not gotten a RNA level checked, we outreach those patients to get their RNA checked. So that system is already in place in regards to stratifying these patients. That's starting from the primary care level, going up to the gastroenterology level.
Yeah, I mean, there are going to be lots of system questions about the coordination between primary care doctors and specialists, and I hope to circle back to that question later this afternoon too. Rita, yeah.
So I'm still concerned about, how this would all play out according to the guidelines in the task force, because in my experience, the people that respond to our calls to do screening are our healthiest patients, not the ones who are sickest at highest risk, most likely to have hep C. And like I said, I've already seen the ads from Gilead to go get screened for hep C. The task force has made a recommendation, which I don't see the evidence to support. And so I see, primary care physicians seeing this check mark in APEX or EPIC, ordering hep C, and then having a patient now who felt perfectly well and now is worried they have hep C. And it really changes your whole quality of life. Maybe you have to have more tests. Now you have to worry, do you have cirrhosis or not? And it's really not clear to me at all from all of the data that we really carefully reviewed today that we're offering any benefit to those patients, but we are offering them a lot of years of concern, and I think that's a big deal, especially with these big campaigns.
Well, I know
And
with
that doesn't
screening-
even get into the cost, which I think is unconscionable.
We'll get there. We'll get there. So let's look a little bit more at the prior auth criteria. So I thought those comments were very helpful in terms of thinking about how well-compensated liver disease might be considered. As you'll know, for Semeprovir, this third page that a lot of it's in yellow, it reflects one health plan's approach to requiring response-guided treatment for Semeprovir and basically limiting the authorization for the number of weeks of treatment according to how the patient is responding to it. Response-guided treatment was really well developed for Telaprevir, or was it Boceprevir? I forget which, or both. Is response-guided treatment something that is a reasonable approach for a health plan to take for coverage and working with its clinicians and patients?
I wouldn't call it response-guided any longer. It's really futility-based. So I think having markers, time points in place to identify futility is important. But the FDA did not recommend response-guided therapy for Semeprovir as opposed to Boceprevir and Telaprevir. So it's two different groups. You know who they are at start.
Right.
And if they meet the futility points, then stop. That's very clear.
Yeah. The fourth page has futility criteria from Humana, which is a slightly different approach. Yes, Kim.
So a parallel or corollary question to that is there any data about resistance and or relapse with these drugs? Especially if they get partially treated? I'm an obstetrician, so sometimes people stop their treatment because they're pregnant, and then does that subsequently impact later when they try to go back on treatment?
So there is resistance data. The protease inhibitor class, which includes the two from 2011 plus Semeprovir, they have a much higher rate of resistance, and virtually all patients who don't achieve an SVR have resistance. Some of them have resistance-associated variants in a small population of their baseline wild-type virus, actually. The polymerase inhibitor, sofosbuvir, has a known resistance mutation that, to my knowledge, has been identified in 2 patients so far, and around 3,000 patients through the clinical development from phase 1. Both of those patients were retreated and achieved sustained virologic responses with additional therapy. The first patient was on monotherapy. The second was treated with 12 weeks and then was retreated for 24 weeks and actually achieved SVR. Those are anecdotal just from the investigators. But resistance for protease inhibitors, the hepatitis C virus is different than other viruses we know more about, such as B and HIV, and that it doesn't have a way to archive itself. It doesn't have a DNA intermediate in its life cycle, and it cannot intercalate its genetic material into the host DNA. So the feeling is that the resistance issue from protease inhibitors probably wanes as those less fit virions die out in the replicative pool that's not meeting resistance, meaning there's no drug pressure once the drug is removed. But the guidelines have been set up with the first development of protease inhibitors. Once you recognize futility markers or the virus is not responding, then further pressure is not a good idea, because resistance could we may find new resistance profiles and compensatory mutations that allow better replicative fitness. So, yeah, those are in place.
Yes, Amity.
So in regards to one issue which we are struggling with is soposbuvir. You know, most clinical trials, whenever a patient missed one pill, because the treatment is so short, when you miss one pill, you were protocol violated. You know, you were off the treatment protocol. We don't have any information about missing 2 days, 4 days, or 5 days. What is worth missing, and when can you say this is enough missing doses? So there's no guidance about that in regards to that medication. So just keeping in that mind that we don't have enough information, and the data we have paucity of data. We in Kaiser have really involved our pharmacy services to make it sure we check viral loads and adherence of the patient and close monitoring in these patients.
Good. There's actually, this may sink onto that. You brought up the question of adherence as an important consideration here. And there are lots of different patient populations that could be taking these medications. The clinical expert criteria that are here in green suggest that perhaps health plans could have a prior authorization criterion that requires the patient verbally or in writing committing to a documented treatment plan, including all the blood tests, et cetera, and that the doctor have a course of treatment. And I'll throw in also that should we require that the doctors who prescribe these medications, very effective in some cases, very expensive, should we only let specialist physicians handle these because of all of the other issues involved? In terms of playing this out, what do we think about requiring patients in some way to commit and having doctors be specialists? Now I can, if that had nothing to do with what you're going to say, go ahead, but I was hoping it would link in.
So what my other comment was, I mean, I think that having a patient who is motivated and able to understand the importance of not missing pills, both because of cost, $1,000 a tablet, and because of the possibility of resistance, should be kind of a absolute criteria. I don't know how best that we can show evidence for a patient's likelihood of compliance, but usually a patient can have some indicator of whether they have a pretty good track record with compliance or not. I mean, I've heard some physicians talk about doing DOT with this treatment.
Can you tell everybody what that means?
Directly observed therapy, like with
Right.
TB treatment. It's obviously not very practical, but there are people who say, you know, I'm just giving anecdotal descriptions of some providers who've said, I'm going to have the patient take the tablet right in front of me if I'm going to prescribe a $1,000 pill tablet. So in terms of patient selection, we're talking about the degree of fibrosis, but I think patient selection, even before that, needs to include a patient who is really able to get their refills on time, come to their visits, do their blood tests, and however one might decide that be documented. Yes. As for the question of should specialists only be allowed to prescribe these drugs, I think for the time being, it's reasonable to say that a specialist or an experienced provider should be the prescriber, but maybe that will change as we have fewer sort of branch points in our decision-making. But I think for the time being, that's reasonable.
Anybody else want to weigh in on that issue of whether primary care doctors should be prescribing these drugs? Are they going to do so in Kaiser, to your knowledge, or is it going to be restricted to the specialty departments?
For now, restricted to specialties.
Specialty. And Todd, how about in Sutter? What are you going to do?
As far as I know, there's no restriction. I think it makes sense for now, but I do think in the very near future, there will be, fewer decisions to make. I think staging of disease from the primary care perspective will be important, and knowing that you're treating something that's viremic and going through the basics. But
Okay. Yes, Doug.
Visit that question I asked several hours ago, which is what's the price to be paid by waiting? And how confident are you that you can monitor people with your clinical evaluation, laboratory testing, et cetera, to reassure patients that, in fact, yes, I can identify when something changes and prescribe a expensive medication, but potentially toxic medication with maybe less than adequate efficacy at the point which we know it really is highly likely to be effective as opposed to less effective. Or I should say the value of treatment will be more effective than, or higher than lower.
I can start with that. So first of all, I think you alluded to this earlier. When we talk about advising a patient to wait, we're not talking about asking them to wait 10 years now. So 10 years ago, when we said you're not interferon eligible or you're not a candidate for this treatment, or we think that you're genotype 1 and have all these poor prognostic variables, we don't advise treatment. Then it was, and we don't know when the next thing will be out that you might be eligible for. But now advising a patient to wait if they're interferon ineligible, or we just think that there's someone who can wait until there's more data, I think we're talking about 12 or 18 months for some additional regimens, 2 years for others. So this is a very slow, indolent disease. So talking to patients about waiting 1 or 2 years, especially if there's someone who's been waiting many years, it feels like nothing to them. In my experience, many of them, if they're not cirrhotic now and they've been waiting, now their choice is interferon or wait another year, and they'll have something that without interferon it's not something that's progressing that rapidly if the patient doesn't already have cirrhosis. Lots of patients have been, put on hold for various reasons up until now, either because they didn't have access, they didn't want interferon, they had all these poor prognostic variables. Does that answer your question a little bit?
Alex.
I have a follow-up question about waiting, and heard some people say that as we wait longer, we'll have new drugs come on the market, and that it's possible costs may come down. I'm wondering what people think about costs over time, and that will they come down? Will they come up as we have new drugs on the market? Are we talking about waiting 7 to 10 years until they're off patent before they're affordable for all patients?
Well, Bob answered that to the best of his ability earlier. Do you remember his answer? It was a good answer. No, he didn't, but
I didn't do the pricing on our product.
He
but
had
I don't
as
think
sophisticated an answer as I've heard, which is...
Yeah, in my 30 years of experience, I don't see that the price is going to go down on the new products that come into the marketplace versus generic competition.
There's a story that you'll find on the business pages about the reasons for some of the reasons for the high prices, trying to recoup investments, et cetera. And imagine that the companies know that their window during which they'll be the best treatment is relatively small. They may be surpassed in 6 months. They have an even smaller time window within which to try to recoup whatever amount they are shooting for. So it creates a lot of different internal incentives, I guess, that are not necessarily headed towards lower prices. So let me, okay, Mary, go ahead. We're going to move on soon to the prior authorization for Sivasbavir, so go ahead.
I was wondering, can I switch to a different
absolutely.
question? Okay,
Oh, yeah,
so,
yeah.
so one of the other things that, is listed by at least some entity here was, had to do with the P450 CYP34A interactions. And, some of the drugs are not commonly used, but some of them are very commonly used, like the statins. And I wonder, especially in the age group that we're talking about, so I wonder, is this like a serious issue, or is this something that comes up in clinical practice, or, how big of a deal is that?
Yeah, the drug-drug interactions for the protease inhibitors are more problematic. Cimeprevir has much less of a powerful interaction than telaprevir and boceprevir did. So the package insert advises us to be careful and to adjust dose and use low doses for things like statins, whereas 2 years ago we were asked pretty much across the board not to use them. So it complicates the regimen for sure. It's usually not a deal breaker, but it's something we have to look at a little. Usually getting pharmacists involved and running the interactions ahead of time to make sure you know what to expect.
Michael?
So I have a question about the numerator. What percentage of folks go on to progress with this disease? There's the 20/20 rule. Is it real?
Yeah, unfortunately, it is real.
Okay. So 20% progress, and then 20% of those get end-stage liver disease or cancer.
The statistic I use is 20 to 30% will develop cirrhosis once they hit chronicity. So there's 70% or so that develop chronicity, which is 6 months of infection or more, those who did not spontaneously clear.
Mm-hmm.
Within that group, there's variability, but on average, 30 to 40 years after infection, there's a 20 to 30% chance of cirrhosis. And once you have cirrhosis, then those other complications are about 1 to 5% per year, which include developing decompensation, the events within that framework, or developing cancer, liver cancer.
So what is the numerator number? Because the question I'm begging here is, why are we talking about treating everyone if a fairly small segment are the ones that are actually at risk? And then, of course, can we predict those folks?
Well, I mentioned what I'm spending my time doing is not treating everyone. I don't have time to treat everybody. So if we're going to talk about rationing care or prioritizing, however you want to term it, I definitely think that patients with advanced fibrosis and cirrhosis, and there are a couple other smaller groups, post-transplant patients with aggressive recurrence, and patients with extrahepatic manifestations that are life-threatening, they should be prioritized. And then to answer the question of how confident are we in evaluating or monitoring patients over time, that's one of the hardest questions I have is, how can I reassure someone who's sitting across the table that they're not going to have a life-threatening complication? It's not easy to do. The gold standard would be to have a biopsy every reasonable interval. 3 to 5 years has been proposed, but biopsies are invasive and expensive and potentially life-threatening. So we've come up with alternate means of these non-invasive blood assays and elastography that are suboptimal for sure. But that, coupled with clinical experience and physical exams, I think we as a group are doing a pretty good job in avoiding missing the patients who are going to progress. But I've seen it, a number of times myself, patients coming back who were reassured that it was unlikely they would have progression or clinical consequences when they did.
So let's try I know Jeff had a quick comment or question, and then we're going to...
Yeah, it's along the same lines, but I'm kind of looking at this number and say, well, there's a fair number that do remain asymptomatic. It's not enormous, but you're still talking 20 to 30% and don't develop liver disease, and a fair number. It's 15 to 25%. It seems to me that we ought to be really maybe the focus ought to be on the better ways to follow these folks, because if you're thinking about it, we always do a risk-benefit analysis whenever we treat anybody with anything. In this case, the risk is, the cost of bankrupting the country and having other treatments not available. And I think that perhaps the answer would be, can we get better at following, screening, systematize that, so that if we're going to go out, and if they've got companies advertising to get everyone screened, and that's the recommendation, I think the focus isn't on treating everyone. The focus should be on when do we treat people and how do we follow them to make sure that we're treating the right folks. And I'm just kind of curious, you said we're not there yet. Are we coming that way? I know that we just reviewed this FibroScan thing and whether it's going to be available and how valuable it is. So there's new things coming.
So is the question, are we there yet in terms of staging or surveillance?
Yeah, to some extent. I mean, the thing is, if we are going to have suddenly everyone in the population screened, we're going to end up with an enormous number of folks that didn't know they had the disease. There'll be a fair number of them that don't have liver disease. You're not used to seeing that because you're at the other end of the funnel. Primary care is at the front end of the funnel. So we've got to think at it from both standpoints. And I'm wondering whether a lot of effort should go into figuring out how we follow these people and then know when to pull the trigger on treatment, because that's the only way it's going to become, I think, from analysis that was done, the only way it's going to become cost effective.
Yeah.
And I'm wondering about whether we're moving in that direction or whether we're still kind of wandering in the wilderness.
I mean, I think we certainly are. The task force, the U.S. Preventative Services Task Force, coming up with a grade B for screening, I think was a huge plus, because I can't emphasize enough how much to ignore the presence or absence of symptoms. If we look at patients as asymptomatic equals fine, that's incredibly dangerous. And every week I see patients who were asymptomatic up until, boom, they have a 7-centimeter hepatoma or development of ascites or admissions for encephalopathy. So again, I do see a small subset, but I think reassuring people that because they feel okay, they are okay from a hepatitis C perspective is dangerous.
All right, thanks. Now we've got about 20 minutes left, so I'm going to forge ahead. I know. I want to move from Cimeprevir forward. Just to note, again, for people who will be using these documents later, at the end are the treatment regimens that are recommended by the specialty societies that are not part of any prior authorization criteria, and the primary one is Cevosbuvir plus Cimeprevir. To date, we were unable to find any insurer that whose public, at least, prior authorization criteria allow coverage for the combination. So we might want to talk about that in a second. When we move to Cevosbuvir, the thing I wanted to talk to you about or a few things, and then Christine, we'll get back if we have time. There's some of the same issues around the criteria for compensated liver disease. The one that stood out here was Humana's approach, which is on the first page, number 10 under patient criteria, and it says the member must have failed to achieve SVR on a prior regimen containing a protease inhibitor before they can get coverage for Cevosbuvir. Now, fail first or step therapies are a common approach in many areas of medicine where patients are asked to try one approach, and then if that doesn't work, then they can get the next one. Basically, John, have you thought about this approach at all for Blue Shield, or Sylvia, is this something that you're even remotely considering? And then I know we've been focusing a lot on the clinical experts, but I wanted to get your input first.
No, we have not gone to this approach for two reasons. Number one, as has been pointed out already, is not part of the society recommendation. In fact, Telaprevir and Boceprevir is no longer considered a standard of care, so to speak, right? So that's number one. And number two, something that was said earlier by the hepatology experts that very much resonated with me. And I have to say that at Blue Shield we have a coverage strategy, although in my opinion it's not much of one, but it is a bit of a hope and a prayer in the sense that most of these patients will be managed by hepatologists, and that most informed and well-reasoned hepatologists would put off treatment for most of them, because right now the guidelines are still recommending for interferon-eligible patients an interferon-based regimen, which would lead us to believe is not the way to go, that they're going to continue to advise their patients. So in a way, we're kicking the can down the road. But for those two reasons, we have not put Boceprevir or Telaprevir as step therapy.
Or sivosbuvir or
I mean,
sibeprenvir.
right.
Right.
No, I'm talking about we're not putting the
Or
two.
not even, right.
We're not putting the two first-generation protease inhibitors as step therapy ahead of.
Okay. Sylvia, do you have any comment?
We're not putting it as a step therapy because it's not a recommendation of the professional society.
All right. I'm just going to make a recommendation then on behalf of CTAF. You guys, this is a stipulation. I stipulate that professional societies who wish to put out authoritative guidelines not seek drug industry funding for the process, and make the conflict of interest information about each individual panel member easily available on the website where you would read the guidelines. None of this happened for this round of specialty guidelines, and I think it is a recommendation that I would stipulate. Do I have a vote on behalf of the CTAF panel? And then we will invite comment.
Well, can you expand on that? Because I'm not aware, my understanding is that the ASLD-IDSA guidelines process was not funded by the pharmaceutical companies, and I know that the co-chairs themselves do not take any consulting money from, so can you just clarify a little bit? Because this is the second time you've brought this up.
Sure. Who's got the brochure? There's a third entity that the logo is smaller. It's called the Antiviral Institute.
IAS USA.
Institute for Antiviral Science Studies. I went to its website and it looked like it was 100% funded by industry.
I think this is something
Yeah.
really important to clarify and make
Yeah.
sure everybody, because it's come
Yeah.
out twice, and this is a lot of folks are holding this as the gold standard.
Well, that's
These
my point.
These are
That's my
experts
point.
in the disease who went through a very thoughtful process. Maybe not everybody is following them, but they're
Right.
not just a society guidelines. They're created by experts with community input and in a very thoughtful
Right.
process.
I think my recommendation, at least that we voted on, well, we had a nodding of heads, was that the process would benefit from greater transparency about conflict of interest and the absence of drug funding. Absence. Yes, Rena.
I wish they were available today, but I will just add that the VA has their own set of guidelines that will be coming out in the next couple of weeks, and I was on that committee. There are 8 people on that committee, and it's a combination of hepatologists and pharmacists and transplant hepatologists, and I think only one person maybe has any support from industry, and that would be totally disclosed. So I will say that there will be another set of guidelines that will be publicly available, and I wish they were today, but they're not.
All right, thanks. Yes, Christine.
One of the things that's kind of the other side to what your point was is that what about the people at the other end who maybe will not see a benefit because of other life-limiting conditions? So much in the way that we're starting to curtail colon cancer screening in patients with lower life expectancies. Is there a place for a similar approach to this disease as well?
Todd or Amandeep or Rena?
Yeah, I think patients with decompensated cirrhosis who are not transplant candidates, there's a big question there. Patients with advanced cancer, liver cancer, who are not transplant candidates, I think there's a big question. Patients of advanced age with early stage disease, I wouldn't make that a priority to offer treatment. And patients with major comorbidities, life-limiting comorbidities, you'd have to certainly weigh risks and benefits, and I wouldn't make that a priority to offer hepatitis C therapy in favor of someone who did not have those.
Yeah, I mean, if somebody has a short life expectancy for some other reason, and we don't think that their lifespan is going to be limited by their liver disease, then I would argue that they probably shouldn't be put on this hepatitis C treatment. But I'll just throw in one really fast anecdote. I think Jeff heard me say this one once before, but a patient was referred to me who had a metastatic recurrent head and neck cancer, who wanted a compassionate drug from Genentech, and Genentech said, we're not going to give it to you unless your hepatitis C is cleared first.
Also,
competing priorities.
Interesting.
Also, anybody with cardiovascular disease, still we have ribavirin as a part of our medication combination, and we know it can cause hemolytic anemia. So if somebody has really significant cardiovascular disease, you have to think.
So the last thing I wanted to point out about the comparative prior authorization criteria, and we don't really have time to work through it here too much, but there may be differing criteria depending on whether patients are interferon ineligible or intolerant. And as you'll see, there are very, very different ways of describing what that means. So maybe if we have 2 minutes, if again, guidance perhaps from the clinical experts, do you feel there's a best practice in how to define interferon ineligible and intolerant that you think would be helpful? Should it be for instance, there are some very, specific, detailed lists of criteria. Some just say ineligible, intolerant, or unwilling. What would be helpful from a prior auth perspective, in your opinion?
You can either be very inclusive or very exclusive with this. I mean, you can give a very long list of all the reasons someone might be interferon ineligible, or the other way around. But to me, one of the key cutoffs should be their platelet count. Interferon causes thrombocytopenia. So we get into a situation where we have cirrhotics who already have a low platelet count, and then if you give them interferon, their platelet count drops to 10. So that's usually at the top of my list, but there's plenty of others. I think that some of the old notions about who should not get interferon, like someone who has any alcohol in their lifestyle whatsoever, most of that I would say is passé, but that those are not included in interferon ineligibility anymore.
Okay. So with just a few minutes left, one other comment about the professional society guidelines is that they didn't explicitly at least address the issue of cost at all. So let's now kind of broaden the conversation again. We've been talking a lot about managing patient criteria, clinician criteria. Cost is part of this kind of stool that we're trying to, stand on, I guess, or work from. And Bob, I know that, industry, and I'm not talking about just your company, but industry has talked about having patient support, programs for patients who can't, afford this. There's talk about rebates for certain public insurers. What do you think is the overall industry approach towards collaborating on the affordability of this from a payer perspective? I mean, what's their view? How do we engage with manufacturers in a way to address this, not just here and today, but kind of going forward?
I don't know. I've got the answer for you. It's, as far as patients with regards to affordability, I think pharma has always had some degree of patient assistance that's out there. But as far as it relates to my colleague, Dr. Yao, and affordability for the health plan, I mean, I think it's the standard business that we usually work under is, whatever discounts that they're willing to offer. Beyond that, I mean, I don't have an answer.
Because, I mean, what I hear, and many of us have read in the newspapers, is a general feeling that in some ways hepatitis C feels like a public health almost emergency. I mean, it's a public health it's a big problem at a public health level. And the pricing of the drugs is reflecting a model that's more, I guess you'd say payers are more used to paying for, smaller patient populations, for rare conditions, et cetera. So there's a feeling that we've all shared this idea that our system is somehow unsustainable, but here we are at a point where it really seems that the innovation pipeline and the payment model that we have doesn't seem to fit well with a public health kind of prevalence. So I'll invite the payers too, but I mean, do you know of any guidance or ways that, or approaches to this problem that you can suggest that CTAF recommend or talk further about or engage with industry around?
Yeah, I could probably think of a few things that I wouldn't want to put on the public record, but beyond that, when you look at hepatitis C, this is kind of the way I look at it. It's, you know, there'll be a public outcry for treatment. And the question is, when do you treat patients? And the biggest question I get whenever I go in to see a payer is they'll ask me, can you tell us when we should treat patients? And I don't have the answer. And I think that that's the bigger question, is not, do you treat everybody all at once, which is essentially what we're talking about right here, versus stretching it out over time. And that's going to be uncomfortable for a patient who has hepatitis C, because if I had hep C, I'd want to be treated tomorrow. I would not want to be walking around with the virus and the potential for transmission to my wife or whatever. I mean, nobody's mentioned that. I mean, there are other people involved in the hepatitis C milieu, if you will, and it's difficult. The answer is, I think you can't treat everybody all at once. But then again, do you want 60 minutes in front of your health plan when you deny care to a certain patient because they don't meet a criteria?
Okay, Sylvia or John, perhaps? Is the system broken? What's the way forward?
Well, couple of thoughts. First, the coverage criteria that we have at Blue Shield, personally, I don't think is sustainable, because my personal opinion is we need some kind of stratification, that we can't afford to treat everyone that has a positive viremia, period. That being said, I think the struggle that we've been talking about, Rita brought it up first, I think, and then since then it's been asked 2 or 3 times over by various panelists, is the fact of the matter is we have an imperfect, very imperfect risk calculator. And we're really dealing with a medical ethics question, you know. And I agree that for now, really our strategy amounts to kicking the can down the road, because we are very much hoping that not everyone's going to be treated. We're hoping that it's going to be a 9% or fewer people that's going to be treated, because it's still interferon-based for interferon-eligible patients. But 10 months from now, 12 months from now, that probably won't be the case, and then we'll have to reassess our strategy.
All right, Sylvia?
I think the treatment, whatever it evolves to in the next 3 or 4 years, is still going to be something that has significant costs to the system. And so prior authorization criteria talk about me getting mine, but we really haven't talked about a societal, insurance is a mutual benefit society. So I have to be willing to pay for someone else getting theirs, which will benefit society but may not directly benefit me, even though I personally may pay a higher premium. And I think that's one of the benefits of a public forum, wrestling these very difficult issues, is that it's not just me getting mine. It's that as a member of society, my responsibility to ensure that other people who I may never see, who have no relation to me, get theirs, because it's a public health benefit. And I think kicking the can down the road we need to do, and lowering the price we need to do. But if individuals are unwilling to pay $10 a month extra per member per month to cover this, even after we've found who to treat when and we've got the price right, we still have this view of, if people think health insurance is only supposed to be $40 a month, this is not going to be sustainable. And I think that's part of the reason of really wrestling publicly, and I think I credit everybody for the investment in time, but that's the takeaway message, because it's not going to be $10 PMPM.
Right. So this is one of those situations. We've had interesting metaphors. We've had warehousing patients. We've had a lot of kicking the can down the road. And we also have the hot potato. So you've probably read in the paper again that there are managed Medicaid programs who were budgeted last year for this year, who were saying, so we didn't get money in our budget to pay for these new drugs, so back to you, state legislature, or state, you're going to have to pay for this somehow. I hear, from private payers, we're going to have to go to our purchasers and say, because of hepatitis C, we're going to be coming to ask you for X more dollars per head. I'm not sure how that's going to play out. I know none of us are, but it's something that I hear a lot about people looking for somebody else to help with the lift on this from a financial perspective.
I'll just say one more thing that's obvious to everyone, and ultimately, that is ultimately the cost is going to be passed down to the consumer, of course. I mean, that goes without saying. And in terms of negotiating for drug rebates or discount, it really works to a very, very small extent. And usually, it doesn't amount to any kind of a solution.
All right. Marge, you had wanted to say something earlier, and I didn't give you a chance. Is it completely gone? All right.
Is simply
Why don't
the,
you use that, sorry.
sorry, simply the acknowledgement that the only reason we're here having this conversation is because it's costly. I mean, otherwise, they're great drugs. Why not? So is everybody prepared to say out loud, the reason we're having really strict criteria for who gets the treatment is because it's too costly. It has nothing to do with patient harms. It's all about cost. And I don't know whether our esteemed panel of providers are prepared to say that, or whether we can say that even now in this California environment. That's all I was going to say.
That's worth saying at the end. Rita?
Well, I actually think it's not just about the cost, Marge. I think it's about the evidence, and I think we have to establish that this is clinically effective and that it's where the risks outweigh the benefits, and I don't think we've answered those questions. And I think clearly the cost, is staggering, but you really want to do the right thing for all the patients, and I don't think that we have established, and I think our votes kind of reflected that. We were all over the place.
I'm not disagreeing with that, except if I were to say, what if the evidence were in now? Would our decision be any easier if, in fact, we actually knew that these drugs were really dynamite?
Well, it would be good if the evidence was in, and then we could have that discussion.
So I'd like to suggest two other potential recommendations to stipulate. One is, and I think this was a missed opportunity, there's been a lot of talk internationally about manufacturers meeting not just with regulators to find out what adequate evidence would look like or good evidence, but meeting with payers and other public representatives. And I think a group like CTAF would have liked to have seen head-to-head trials. They would have liked to have seen perhaps longer duration. There are ways that might not have actually been that expensive for the manufacturers to create a body of evidence that would have been stronger from the perspective of CTAF. So I think going forward, would we want to suggest that the manufacturers consider working with payers and other public review groups to try to understand what adequate evidence would look like to groups like this? Is that reasonable? Good. And the last thing I would say before we really start to wrap up quickly is about better evidence. Some payers may consider coverage with evidence development in this area, whether it's through registries or some kind of pragmatic trials going forward. And I had a communication from Joe Selby, the head of the Patient-Centered Outcomes Research Institute, who said that they were very interested in this meeting and wanted to convey that they have $10 to $20 million on the table for pragmatic trials of hepatitis C drugs that they would love to give away to people with good proposals. So for those of you in the research community and from a variety of perspectives, think about the opportunities that might be available to generate better evidence, but I also think we can do some preventive medicine on the front end to get better evidence even as they come through FDA.
Can I just say one more thing about evidence in terms of putting it into perspective? And I don't disagree with what Rita just said. In fact, I love her debate, about statin and all that discussion in the past. But when it comes to drugs, though, it's a little bit different from the payer's perspective, and this is just a real-world perspective, right? Everyone looks at the FDA as the evidence judiciary body. So in a way, I don't want to say anything that's politically incorrect, but when the FDA approves something and has approved indications, that becomes the evidence. And we as payers really have to struggle with that because everything else is secondary.
Understood. I'm going to move up here. I want to be sensitive to the people who've made plans to leave for the airport, et cetera. I have just a couple of housekeeping activities. Could we have the slides, please? Up. Thank you. So further public comments are welcome until March 17th. We often continue to learn things. We are going to work with a variety of different practice groups and payers to get this word out. As you notice, there's been a lot of media attention, and there will continue to be so. For CTAF, the next meeting is already set now for July 11th, 2014 in Los Angeles. The treatment of migraine headaches, I think I've got one now, and so we'll find out what's effective. We probably won't be dealing with the same scale or magnitude of some of these financial and other issues. I need to thank very, very deeply the contributions of the members of the Policy Roundtable. You see them here today, but many of them have been talking to us since we started this review. They've given us clinical insights, policy insights. They've helped us scope this from day one. So I'd like to give a special round of applause right now for the Policy Roundtable. I'd also like to congratulate the inaugural meeting for the new CTAF members. As I said, believe me, it will only get easier from here. I'd like to thank Karen Shore and the program director for CTAF for all of her support of this at the intellectual and at the programmatic level, to Jeff and to Dan for the review. And I'd like to take one last opportunity to address those on the webcast and those of you in the audience. This is something that really involves all of us, obviously, in terms of going forward from here and trying to figure out how to understand this evidence and to apply it responsibly in the healthcare system. CTAF views this topic as one of central importance, and we will choose opportunities to revisit it as new drugs come online and as further evidence is generated. So we hope we've been helpful today, and we also look forward to feedback from stakeholders on how we can tailor this process to provide both a meeting and the reports in ways that can be helpful to other decision makers. So thanks for your attendance today, and safe travels to everybody.